I'm going to talk mostly about smart health that we deployed in Indonesia, and colleagues also deployed in India and China, but I'll talk about that in Indonesia. And this is joint work with colleagues in Australia, in Indonesia, of course, and myself at the Global Development Institute. SMART actually stands for, it's an acronym, but I'm not going to spell it out for you because it's long. It's a personalized healthcare for the management of non-communicable diseases in developing countries. As Sabine said, this particular application is on heart or cardiovascular disease risk management. A little bit about myself. I study and teach global health inequalities. So a few years ago, for the 70th anniversary of the NHS, we put together a bid, and we got it for the NIHR Older People and Frailty. So I'm partly there. Most of my time actually study health inequalities in the UK. So this is maps of dementia prevalence across local districts in England that we present to the government, and we publish in International Journal of Geriatric Psychiatry. And recently I look at the long arm of childhood conditions that raises health inequalities in older age. So I look at childhood poverty, epigenetic aging, and later life health in 28 countries, 28 wealthy countries. But as Sabine found out, I'm from Indonesia, so I'm going to talk to you about Indonesia for the rest of my talk. So here it is. Most people with heart disease receive no treatment whatsoever. This is an unfortunate finding that Yusuf and others reported in Lancet in 2011. And I can tell you that the figure you see on the rightmost block, low-income countries, more than 3/4 have unmet need for cardiovascular care. And when we look at specifically in the case of Indonesia in 2014 with a student of mine, we find that at the bottom, 70% of respondents with moderate to high cardiovascular risk have unmet need. They were not aware of it. They received no treatment or secondary prevention whatsoever. So this is the situations in the world and in Indonesia in particular. And a group of colleagues from the Global Health Institute, the George Global Health Institute, came to talk to us and to do something about it. And I'm going to play a video of Smart Health to tell you a little bit more of what we did there. Tell me if you have any problem seeing and hearing this video.
Smart Health is a platform. It's a platform by which we can deliver essential, affordable, effective care to those people who most need it and can least afford it.
To tackle the accelerating problem of chronic conditions in low and middle income countries, the George Institute has developed an intervention which enables the local healthcare workforce to perform primary healthcare. It is called Smart Health.
We've declared that primary healthcare for all is a fundamental pillar that all healthcare systems around the world should be striving for. And yet, 4 decades later, we still haven't achieved that. And we know what works. What we don't know is how to implement that at scale, and that's what Smart Health is trying to address.
We recognize that there's not enough doctors to deliver the type of care that's needed. And quite frankly, the preventive care of most chronic diseases does not require doctors.
With modern technology, Smart Health enables local community health workers to take an active part in preventing chronic conditions.
It is actually, at heart, a social intervention equipped with technology.
So how does it work? Community health workers screen their local community for chronic conditions by doing physical measurements and interviews. All the data they collect goes into the app, which calculates if the person is at risk of developing chronic conditions. If the person is in high risk, they are referred to a local doctor. The doctor has access to all the data which was collected in the screening, which makes it easier for him to diagnose the patient. After the person has been diagnosed, the community health workers make follow-up visits to support the people with their treatment.
So we've been able to take the concept of the Smart Health platform and convert it into individual projects in a number of countries, in a number of settings, for a number of conditions over the last 10 years. And we've learned a number of really important lessons along the way about how to increase the chances that the Smart Health platform will be affordable, acceptable, and effective in producing the type of improvements in health that we're looking for.
The most recent study was conducted in Indonesia, where 11,000 people were screened for cardiovascular diseases over a 12-month period. The intervention has proven to be successful.
After 1 year of intervention, now we have the increased number of people taking medication from 20% into almost 80%.
As more people received treatment, the average blood pressure level fell significantly.
So really we're seeing the whole chain being improved, community acceptance, better prescribing of recommended medicines, and now lowering of risk factor levels that we know cause avoidable deaths and disabilities.
We found that once you stop this program, then in some instances, the number of people who are not on treatment goes back up. So what it also shows is that while this program works, as long as it is there, this needs to be continued.
The health authorities in the district where Smart Health was implemented are supporting the program.
Bagus sekali di Kabupaten Malang di bidang kesehatan. Ini sangat terkesan sinergisitasnya sangat baik dan banyak membantu program-program kesehatan di kabupaten, terutama penyakit-penyakit yang tidak menular.
We've managed to raise over $10 million over the last 10 years to do these projects in various countries. And we've learned the hard way. We've learned by failing sometimes. We've learned by really engaging with the local communities, local healthcare providers, learning from them how we can modify the program to be most effective locally. So it's been a slow but very fruitful process to get to the point we're at now, where we can actually implement Smart Health in different settings with local adaptations.
So here is the result that we got from the intervention over the past 2 years of intervention. There's a number of papers, but I'll just speak to 2 of them. We reported in PLOS One cardiovascular disease risk factor prevalence and 10 years risk of death, the usual stuff that we see in this kind of study. We have 8 villages. On the left are the control, on the right are the intervention villages. And of course, as you probably see there, we trained local health workers. She's right there in the middle. Typically, she has only got high school degree. She didn't go to university. That's the typical situations with local community health workers in Indonesia. So we trained them to get some blood measurements, get blood pressure measurements, weight and height, and so on. So that's how we begin to involve them. And these are some of the activities in the communities. This is community health post at the level of villages or hamlets. And above them is the primary healthcare. So one primary healthcare serves tens of these community activities. And the results we report in JAMA Cardiology, and the bottom of that highlighted high-risk individuals in intervention villages, 15.5% of them take appropriate preventive medication, compared to only 1% in controlled villages. So 14% difference in there. And some of the extra details, if you want to look at it, we have improved appropriate treatment, first row, third from the right column, adjusted relative risk is 14.8. So there is an increase in appropriate treatment in the intervention villages. The difference between the 15.5 and 1% that I alluded to earlier. More of the outcomes you can see on the second rows all the way down. The point is the intervention works in terms of securing appropriate treatment, reducing blood pressure, and so on. I then went to write an impact case for this one. Some of you in the UK are familiar with the research excellence framework that we completed recently. So I wrote this particular impact, and we got good results for GDI there. And the university highlighted that in the cases that we say contributed to reduced inequalities as one of the Sustainable Development Goals. Finally, I want to mention this because of the serendipity that happens as we have this intervention in place. No one predicted COVID, but because we have this intervention in place before COVID hit the world, if you notice, COVID hit people with comorbidities, and in particular, diabetes and cardiovascular disease. And we were lucky, that's where the serendipity comes in, that people in the control villages compared to people in the intervention villages have different behaviors as a result of this intervention with respect to cardiovascular disease risk management. People in the intervention villages were very careful before this COVID struck. They adhere to treatment, they take their statins regularly, and we see as a result, throughout the course of the pandemic, you see on the left graph there, the control villages, the blue ones, have very high cumulative incidence of CVD mortality, whereas the intervention villages, they have much lower cumulative incidence of CVD mortality. And that can be attributed to the fact that they are part of the smart health intervention. So when something, a shock like COVID that no one had predicted come, they reap the serendipitous benefit of being able to control their cardiovascular risk and therefore the risk from dying from COVID-19, which is different from the one on the right column, one on the right plot. So in conclusion, smart health works, and at the moment I can tell you it's being scaled up to the whole area of the district, whole Kabupaten, instead of just 8 villages I showed you earlier. And it's also being absorbed and owned by local government and the people. So it's now part of the local government or electronic health record system, e-Puskesmas, they call it in Indonesia. It's the reason for that because it's also cost effective. We have a paper in health policy and planning, which I do not talk about. If I reflect, I believe that there are 2 keys in the success and the adoption and the scaling up of this intervention. Of course, technology is one. It's very easy now to devise the algorithm and put it in a tablet or mobile phone and give it to the local community workers who didn't go to university. Anyone with a high school education can operate one. But the second one, I think, is the engaged community health workers. They are very much part of what we bring. In fact, they are among the first to own it or adopt it. And it is not therefore very difficult to convince the district health authority to own it and adopt it similarly. But it begins with the community health workers knowing that it's actually good for them and good for their people in the communities. And last, there is a considerable amount of unmet need for non-communicable disease care in developing countries, including this one, cardiovascular disease and diabetes, but also mental health. And not only in Indonesia, you probably have gathered that we have it in India, colleagues have it in India, in China as well. And I also look at it in Uganda. So there is indeed a considerable amount of unmet need, and something like this can find its place in those places. So finally, my last slide, we're working on this still, apart from scaling it up to beyond the 8 villages. We're working on medicine quality because probably you heard of issues with medicine quality in developing countries that affects statins, amlodipine, captoprils, and so on. So we are checking that too. And also we are considering other non-communicable diseases such as mental health. So I'll stop there and thank you very much.
Thank you, Gendo.